It's Bill Storms talking about another, what I would call clinical conundrum case. Um, this is a patient with poorly controlled asthma, 45-year-old woman, long-standing asthma, albuterol 2 to 3 times a day, non-smoker. Symptoms are daily, worse with pollen and with cat exposure. She denies sinus disease, pneumonia, hives, food allergies. He's had normal chest x-ray, CAT scan in the past. FEV1 is 66% predicted. She was given 4 puffs of albuterol with good technique. Spirometry does not change. So what's going on here? If she's got asthma, why didn't her FEV1 improve? Well, let's look at that. Albuterol versus inhaled steroids. What do you do about this patient? What's your next step? So let's look at the next step. Daily inhaled steroids. Repeat the FEV1 in 3 to 4 weeks because it takes about that long. And her FEV1 improved to 60 from 66 to 79%. So why did this happen? Because the obstruction was driven by airway inflammation, not bronchoconstriction. So the inhaled steroid, not the albuterol, targets the underlying inflammatory pathway. We're very aware of that, but somehow we just keep looking at that pre and post FEV1 when we do spirometry. So we need to look at a delayed improvement in FEV1 3 to 4 weeks later. So this is why a negative bronchodilator response does not rule out asthma. So there are 2 mechanisms: airway obstruction, we all know about this; bronchospasm, which actually is the wrong word, it's bronchoconstriction. And you can see here that smooth muscle constriction. That responds to beta agonists. They usually work within minutes, and you can measure a change in FEV1 acutely. And this bronchoconstriction is triggered by exercise, cold air, allergens, etc. However, airway inflammation, which includes edema, mucus production, and remodeling, only responds to inhaled or oral steroids, and it requires days to weeks to show that improvement. And it's really a different mechanism of action, a genomic mechanism driven by eosinophils, mast cells, cytokines, which obviously are not affected by beta agonists. So albuterol has a mechanism of action. It's a receptor agonist, adenyl cyclase, increased cyclic AMP, and smooth muscle relaxation. And why it failed was that it wasn't bronchoconstriction. The mucosal edema caused by inflammatory mediators, increased vascular permeability in the lung tissues, airway, wall swelling, fixed obstruction. There's mucus plugging, chronic airway inflammation, goblet cell hyperplasia, and viscous secretions which block the small airways. And if the asthma goes on, there's subepithelial fibrosis and smooth muscle hypertrophy, which is only partially reversible. So in this patient, here's a schematic diagram of how the inhaled steroids made her FEV1 better. Day 0, weeks 4. First, they affect the genome. They bind the glucocorticoid receptor, and it takes hours to days to change that gene transcription. Days 1 to 3, there's reduced mast cell degranulation. Days 3 to 7, reduced eosinophils. Week 2 to 3, mucosal edema and the mucus clears. So as you see down the bottom, it gets reduced vascular permeability. So there's less edema. Reduced eosinophils, which suppresses IL-5 driven eosinophilia, steroids do, and less mucus hypersecretion because the steroid reduces goblet cells and the MUC5AC expression, which produces the mucus. So in clinical practice, I do use albuterol for acute reversibility, but if it doesn't work, then inhaled steroids for a chronic reversibility. In fact, when I treat the patients, I typically would use an ICS-LABA combination rather than ICS alone. But I use the ICS alone in this short talk just to demonstrate the difference. Plenty of references here if you'd like them.